Assalamu alaikum wa rahmatullah. Welcome back. And this is the second part of the lecture. We'll be talking about disorders of the red blood cells and platelets. And when we are talking about red blood cells disorders, we are talking about anemias and different types of anemias. We have iron deficiency anemia, folate deficiency anemia, hemolytic anemia, and hemolytic anemia, which is related to destruction of the red blood cells, which are seen in cases of sickle cell anemia, thalassemia, and glucose 6-phosphate dehydrogenase deficiency. And the last type of anemia is aplastic anemia. So anemia, generally speaking, is a reduction in the oxygen carrying capacity of the blood, regardless of the cause of that. This can be related to a decrease in the number of the circulating red blood cells due to abnormality in the bone marrow or certain medications, or maybe this can be related to abnormality in the hemoglobin structure, as in some cases of hemolytic anemia. And regardless of the case or of the reason, there is a decrease in the total number of red blood cells, which will in turn reduce the amount of oxygen that reaches the tissues. The red blood cells could have irregular size, as we can see in microcytic anemia and iron deficiency anemia, or larger size, as in megaloblastic anemia, or abnormal shape of the red blood cells, as in the case of sickle cell anemia, where there's sickling of the red blood cell. So to synthesize a normal red blood cell, we need iron, we need vitamin B12 and folic acids, we need a normal intrinsic factor, which is important in the absorption of the B12. So if the patient is not having this intrinsic factor, the patient, although he's taking adequate amount of B12 and folic acid, the patient cannot absorb these supplements or these nutrients. Also, we need a normal globin protein synthesis, and this requires normal genes that are responsible for synthesizing the globin proteins, and normal nutrients, normal proteins that makes the building blocks of the globin protein. Also, we need a normally functioning bone marrow that can produce normal red blood cell. So failure of the bone marrow, failure of or abnormality in the genes responsible for producing the globin protein, lack of the building blocks of the amino acids related to nutritional deficiencies, severe nutritional deficiencies, abnormal or non-functioning intrinsic factor, low amount of iron, low amount of B12 and folic acid. All of these factors might, if were not available, they will induce anemia. Let's start with the most common type of anemia, which is iron deficiency anemia. So it is either caused by poor intake, the patient is not taking adequate amount of iron, or cannot absorb the iron because abnormality in the stomach, or cannot, or because of excessive need for the iron, like in case of pregnancy, or sometimes excessive loss of the iron. The patient is taking adequate amount of iron, but there is a continuous loss of the blood that will reduce the total amount of blood, of RBCs, and of iron available in the body, as in the case of hemorrhoids, or maybe severe menses in females, or low-grade bleeding or ulcer present in the gastric mucosa. This will also lead to iron deficiency. So these are the causes of iron deficiency anemia, and it's not enough to measure the hemoglobin to know if the patient is anemic or not. There are other indicators that present or indicate the presence of anemia at early stages. We usually measure ferritin serum level, which are the proteins that stores the iron, because iron cannot move as free iron in the serum. It needs to be binded to a protein, and this protein is called ferritin. So when we have low amount of ferritin, this indicates there is no adequate amount of iron in the body, and there is no stores of iron. Transferrin serum level, which is another protein, and this protein is responsible for transferring the ferritin holding the iron from one area to another, and it indicates the presence of iron in the tissues. Hemoglobin level within the RBCs. We'll talk about this later in more details. Sideropenia is a case where there is a normal hemoglobin, but the serum iron is low, which means that the stores are depleted, but still the amount of hemoglobin is within normal range. So we cannot say that the patient is anemic, but he is sideropenic. This shows the difference between a normal red blood cell and the red blood cell in iron deficient in iron deficiency anemia. You can see the RBCs are smaller in size, they are microcytic, and they are hypochromic. The pigmentation is reduced as well. So this is the stages of iron deficiency. The first stage, when there is no anemia yet, the iron stores are depleted, so this is why there is a lower amount of ferritin. There is no need for synthesizing ferritin to hold iron, because there is no iron, no stores of iron. The second stage, if the condition continues, there's going to be latent iron. We call it like a latent iron deficiency, which means that it's not just the low amount of ferritin, but also the serum transferrin is elevated, which means there is empty transferrin. It's like empty taxis holding or transferring the ferritin from one place into another. These transferrin, they are empty. They do not hold the ferritin. So the saturation of the transferrin is low, which means lots of empty transferrin, and the serum transferrin will be elevated because there is no transferrin located in the tissues, because they are not holding the ferritin. The third stage, where there is an iron deficiency, and now we call the patient is anemic, when there is low hemoglobin. So do not wait for low hemoglobin to diagnose the patient. Patient can be diagnosed and can be presented with symptoms, mainly oral symptoms, as early as in the stage 1, even before having low hemoglobin. So asking for a CBC that present or that shows you the hemoglobin is not adequate to detect any deficiency of iron in that patient. So these are some of the symptoms that might be present in patients with iron deficiency anemia. The first one is koilonychias, which is spoon-shaped nails. This is related to anemia. Pale conjunctiva, pale mucosa, presence of angular cheilitis, and depapillated tongue. Because generally speaking, if there is low amount of iron in the serum, the tissues will make certain modifications because of these deficient amount of oxygen that reaches the tissues. So instead of having, for example, 10 layers of epithelium, the tissues will tend to reduce the number of layers of epithelium, and there is generalized thinning of the mucosa. The most easier one to be detected or to be seen is the oral mucosa. So this is why many patients can be detected at early stages of pseudopenia based on the oral symptoms. Other signs and symptoms include presence of certain infections like oral candidiasis, because candida loves abnormal mucosa, loves atrophic mucosa, so they tend to grow at areas of atrophic mucosa. Patient will have RAS-like ulcers, erythematous mucositis, and burning mouth. All of these are related to the thinning of the mucosa, related to decreased amount of oxygen that can be provided by the blood supply. Management, it's not enough just to correct the decrease in the amount of iron by providing iron supplements or iron tablets. You need also to determine the cause of the iron deficiency and to correct it. This is usually the responsibility of the medical profession, and but your role is to detect the abnormality and refer the patient. Replacement therapy includes ferrous sulfate 3 times a day. So note, this is a therapeutic dose, not the dose that is provided as just a supplement. And some patients cannot tolerate the side effects of the ferrous sulfate, including nausea, epigastric pain, constipation is the main complaint of the patient receiving or taking iron tablets. So parenteral administration can be provided. And also you need to make sure that there is an improvement after providing this medication after 4 to 8 weeks. The other type of anemia, which is related to vitamin B12 and folic acid deficiency, the blood cells will appear larger in size, and this is why it's called megaloblastic anemia. In most cases of vitamin B12 and folic acid anemia, the reason is a problem in absorption rather than the intake of these supplements. And the problem of absorption is related to lack of the intrinsic factor that is needed to absorb these substances. One of the conditions related to that is pernicious anemia, which is an autoimmune disease where there is autoantibodies that destruct the intrinsic factor. And for those patients, any oral intake of these supplements would not be adequate or would not be enough to manage this condition. Usually they need a parenteral administration of the vitamins. Another cause is malabsorption due to GI disease, for example, presence of atrophy in the gastric mucosa, as in the GI disease in Crohn's or inflammatory bowel diseases, or may be related to surgical removal of the stomach or part of the stomach. Dietary deficiency can be seen mainly in strict vegetarians. However, patients with normal diet, usually they do not suffer from these types of deficiencies. Drug-induced, some medication might affect the absorption of these supplements. Examples include oral contraceptives, anticonvulsants like phenytoin. Methotrexate is known to reduce the amount of folic acid. So usually when methotrexate is prescribed for any patients, usually we prescribe folic acid supplements to be taken as long as the patient is taking methotrexate medication. And the last cause is the increased demand, like in case of pregnancies, the patient or the mother should increase the intake of these supplements or of these vitamins, because there is a physiological increase in the demand or in the need for those supplements. Clinical presentation: there are general clinical signs and symptoms, including neurological, mainly paresthesia and tingling sensation in the fingers and in the feet, muscle weakness, syncope, psychiatric, including fatigue, depression, mild memory loss. Oral symptoms and signs include burning sensation, also paresthesia, maybe in the lips or tongue, and patchy areas of erythema in the tongue and the mucosa, which is erythematous mucositis, again related to the thinning of the oral epithelium. Management: if the patient had a problem in absorption, as in case of pernicious anemia, the patient should take injections. Usually they are prescribed 1000 microgram taken daily for a week, and then one injection every week, and then every month. If there is no problem in the stomach or in the intrinsic factor, the patient can take oral B12. High doses, of course, it would be higher than the ones are given parenterally, and high doses of vitamin B12 might help even in case of for maintenance, even in cases of pernicious anemia. This shows the changes here in the tongue for a patient suffering from pernicious anemia, and after prescribing vitamin B12, you can see the improvement in the tongue. The patches of erythema disappeared, depapillation disappeared, and normal papilla are being developed in the tongue. Hemolytic anemia is the increase in the destruction of the erythrocyte, and this can be related to abnormal structure of the globin protein, as in the case of sickle cell anemia or thalassemia, or might be acquired because of an external factor that destructed these red blood cells. Usually medication might affect or might induce hemolytic anemias. Sickle cell anemia is an example of hemolytic anemia, and it is caused by a mutation in the beta globin gene, and related to this mutation in the DNA, the amino acid sequence has changed, and therefore instead of having glutamine amino acid, now the patient with sickle cell anemia have valine amino acid, and because of this change in one amino acid, now this RBCs is not normal, and under any amount of pressure or stress or hypoxia, this the shape of the beta globin protein would change and will induce sickling in the RBC. Another defect in the globin gene is noted in cases of beta thalassemia. Now those patients, they have a mutation again in the beta globin gene, and this mutation will result in stop codon, so there is no synthesis of the beta globin protein, and those patients will have abnormal beta globin, or they would have no beta globin. It depends on the site of the mutation, how many amino acids were built up during translation. The third type or example of hemolytic anemia is the G6PD. In those patients, they have normal globin protein. There is no problem in the proteins or in the globin proteins that makes the RBCs. However, the problem is in the enzyme, which is glucose 6-phosphatase dehydrogenase enzyme. This enzyme is needed to produce energy from glucose. So when the cell requires extra energy, it uses this enzyme to produce the ATP. Now, as those patients, they have abnormal enzyme, this metabolism is affected. So when the RBC requires extra amount of energy, it fails to produce the ATP from glucose, and this will lead to hemolysis. This cell will die or will induce apoptosis in that cell because it did not make the adequate amount of energy required for survival. So those patients, they usually, have normal RBCs. They do not have any problems unless there is an extra or external factor that induces excessive stress on the RBCs. This includes infection, taking certain types of medication, or certain types of food like fava beans. These substances tend to increase the stress on the RBC, and as it will fail to respond to this demand for energy, the cell will apoptose and will die. So this is another reason for hemolytic anemia. This is how the sickle cell looks like when the process of sickling takes place. We'll talk in more details about sickle cell anemia, and in such, it is an autosomal recessive disorder, so the patient can be a carrier of one defective gene. So he have 50% of these cells are normal, 50 are having the sickle cell RBC, and we call them, they have the trait. Those patients, usually they live normal life, and sickling would be seen only under extreme conditions, and still the patient can manage with half or with the 50% normal RBCs. In the sickle cell disease, when all of the copies of the hemoglobin are defective, they are hemoglobin S. In this case, any problem or any infection or any trigger, or sometimes spontaneous, the patient will have sickling of the RBCs. Now, these sickled RBCs, they do not have the free mobility of the normal RBCs, and usually the patient would have blockage of the blood cells related to these sickled RBCs, and the blood become more viscous, and this will lead to ischemic changes and impaired vascular flow to the tissues, which might be presented with different signs and symptoms, and when severe and acute, we call it sickle cell crisis. These are some of the clinical presentation of the sickle cell anemia. Patient will have prominence of the maxilla and mandible, orofacial pain related to ischemic changes. Also, the patient might have dental pain related to necrosis of the pulp due to sickling crisis. The patient also should be dealt with as a high-risk patient for osteomyelitis and any infection after extraction because of the low vascularity to the blood and incidence of precipitating a sickling crisis during extraction, in addition to peripheral neuropathies. Management of such patient, the main concern for us as dentists is to keep good oral hygiene for such patient to reduce the need for extractions and more aggressive dental treatment. Another thing is prophylactic antibiotics should be given whenever you attempt to do an invasive dental treatment or surgical dental treatment to prevent any infections, because you cannot rely on the normal healing process. And the third point is to reduce the amount of stress associated with any dental procedures by providing good analgesia before, during, and after the dental treatment to reduce the amount of stress and reduce the chances of sickle cell crisis. The last type of anemia is aplastic anemia, and this is a very rare condition. The cause of it is not known, and what happens is a complete failure of the bone marrow. It stops producing any type of cells, no RBCs, no platelets, no white blood cells, and therefore the patient is susceptible to infections, to bleeding, and anemia. Usually this condition is treated with immunosuppressive drugs, and in many cases the patient might require a hematopoietic stem cell transplant to have a new bone marrow that is capable of producing the blood cells. The last topic is going to be about platelet disorders. Generally speaking, platelets abnormality could be on the number of platelets produced, or in the structure, or let's say the molecules present on the surface of the platelets. If the problem is related to a decrease in the number, we call that thrombocytopenia. The normal number of platelet count is range between 150 to 450,000 platelets. Now, if the platelet count is less than 100,000, now the patient is said to be thrombocytopenic, and as the number goes lower, the chances of bleeding would increase. This can be related to just decreased production of platelets as part of aplastic anemia or any hematological deficiencies, as we stated earlier, or it might be related to destruction of the platelets. Excessive destruction of the platelets usually, or the most common type, is immune-mediated thrombocytopenia. In thrombocytopathia, where there is a defective in the function of the platelets because of the abnormality or abnormal molecules on the surface of the platelet. So although the number of platelets is normal, but the platelet cannot function normally, there's a problem in aggregation of the platelets or in adhesion of the platelets to induce clotting. And these conditions are very rare, and usually they are inherited conditions. Those patients, as I said, it depends on the specific type of the thrombocytopenia or thrombocytopathia. The severity of the symptoms vary, could be just mild symptoms, or sometimes it is severe thrombocytopenia or severe thrombocytopathia that is life-threatening. So you need to know if the patient have any tendency for bleeding or a history of prior bleeding during extraction or after extraction. Also, you need to be vigilant to any clinical signs that might be indicative of platelet disorders, like presence of spontaneous gingival bleeding, or presence of petechiae or ecchymosis within the soft tissues, within the oral tissues. So you need to be vigilant to these changes. Now, if your patient is diagnosed with immunothrombocytopenia, for example, you need to know the platelet count prior of doing any sort of dental treatment. You need to discuss the patient's condition with the medical doctor or with the hematologist. Some patients might require platelet transfusion before conducting any surgical dental treatment. Also, you need to pay attention to local measures in controlling bleeding, which are really effective in such patients, it is, it works very well that it will reduce the number of times that the patient might require a platelet transfusion. And also, finally, you need to maintain good oral hygiene for those patients, improve their oral hygiene care so that they would not need to go for any sort of aggressive treatment like extractions um, or implants or such treatments that might or that harbors a high risk of bleeding. So this is a general, a quick look on the hematological diseases, kind of a reminder or a revision of such medical or hematological disorders, and what are the signs and symptoms that you need to be aware of, and how to take care of such patients. That's all for this lecture, and see you next time, inshallah. Assalamu alaikum wa rahmatullah.